Thank you very much.
Yeah, your name, sir?
It's Dr. Benjamin Odeka, and I'm a consultant in pediatrics and gastroenterology, and also an expert in medical law and governance. And I work part in the UK and also part as a chief executive of Lady Helen Child Foundation.
Very briefly, I read a few things about what Lady Helen Child Health Foundation does. But what actually struck me was the real reason, to entrench, good governance in the health sector. So talk to us about what Lady Helen does along that line.
Okay, my training in medicine is broad. I qualified as a doctor in 1980, and I've been a consultant since 1994 in the UK. And some of the things I do, apart from treating acute pediatric patients, I also manage. So management deals with governance. And I was a clinical director for almost 10 years and a medical director for 5 years. And since then I've been in quality assurance in the NHS, that's CQC, visiting hospitals in the UK, assessing their standards and giving reports if they are not performing well on this. And you can get the results published in the national papers. Now, with that in mind, I know the standard of care for pediatrics and maternal health in the UK. Coming back to Nigeria, visiting and going and coming, I have friends who I trained with at Ibadan. And the level of delivery of the health service within the country, I'm sorry, they're trying, but there are a lot of limitations. And with that, the quality suffers. Governance arrangement, I'm sorry if I have to apologize, does not necessarily exist. Or if it does exist, it's ignored. And there's nothing, patients are not basically respected, which is the tenets of actually delivering healthcare. So that is one of the burning desires. Then the second other burning desire is the fact that even with the scarce resources, they are not targeted to the needy ones. The needy ones are actually the ones that want it, they strive for it, they can't get it, they're frustrated, and even in that frustration, people who are meant to actually empathize with them don't even look at their faces. So you can get that, it's a double whammy if I call it that way. You don't get it, you can't get it, and you're actually ridiculed. So those are the basic failure of governance within the system. So part of for services to these children, they can't afford it. So that's an aspect we deal with in our PTAP format. PTAP simply means Patient Treatment Assistance Program. So for instance, we did a survey within the FCT. Some kids go to hospital for treatment. At the end of treatment, they can't pay. And the hospitals don't want to discharge them. So I cannot understand that. You have a patient who cannot afford to pay. You keep them in hospital for how long? So you occupy that bed. What about the next patient? They can't get that bed. The person can't pay. So it doesn't make sense. So with that, we have the PTAP format. So those patients can be identified, and whatever level of support we can give them to effect discharge, we do that. We've done that for quite a few within the hospital, national hospital and stuff like that. They call us, we have a format for doing that. So that's an aspect to try and help within that sector. Then in terms of advocacy, this our lecture series is part of the advocacy, looking at policies, looking at the delivery, looking at the usage, and actually trying to put things together to see if we can come up with solutions. Because it's very easy for people to come up with solutions. If I ask you a question, you have a lot of problems. You have a lot of problems. What are the solutions? So we need to vaccinate that solution and see how effectively we can actually make it work. So that's part of our lecture series. Then the other aspect is about the medical law, and that's about governance. I've talked about it a lot. Those are the tripod of what we're here for. So those three things will populate our vision and our mission. So hopefully, if we push enough policymakers, you can see in the gathering here, we've got quite a few, actually attracted quite a few. So the output from this meeting will actually form the pressure point we're going to mount on the policymakers. And actually, with our governance tree, we'll be monitoring how far they are going in terms of delivering on what they say they're going to do. Then what the things they say they've already done, we look at how effective those things are within the general population. We have to ask people who use those things. Not a question of telling me we built X number of primary health care all over the place, and they are occupied by, I'm going to say, reptiles or bushes. And that's not people, isn't it? So we're going to ask those questions. How many people use those things? How many of them in existence? Those are the questions.
Okay. I also like to take you on the 2020 budget proposal.
Right.
The health sector was allocated 46 billion. Is this enough?
I think I try not to look at the amount. I try to look at what it is for. Okay. So what I would like to do is to look at the current provision, look at the current demands, and look at the current facilities that they've got. What are the deficiencies? How are we able to do that? Forget about the money. It's not important. It is what is happening on the shop floor. If you go to hospital today, can you see a doctor or a nurse? Can you? If you can't, how can you make that happen? I'm not bothered about the money. You can pay me 100 billion and people can't get into hospitals. It's immaterial. You understand? So we need to go into those questions. I think journalists should actually be asking those questions. Hospitals, how many times have you dealt with emergencies? How trained are your staff to deal with emergencies? And how many patients have died in your hospitals? Those are the questions, not the money. Forget about the money. It is what is coming out of those institutions that matters, so that people can be accountable for their actions. Because the doctors, I'm sorry to say I'm a doctor, but I'm not trying to flag off anybody, but the doctors should be held accountable. Okay, it's not a question of being a doctor and a chief. It doesn't make sense. If your patients are dying, you're not a doctor. I'm sorry. You need to tell people what you are doing, and people need to evidence your good practice by seeing the outcome of what you do, not the money. Forget about the money. Yeah.
All right, so since 2017 till date, how many
Patient support, moral support, advocacy support, those are the ways I want to quantify that. Okay. In terms of material, for instance, if you go to IDP camps, lots of them. So if you quantify them in terms of numbers, you see how big that can be. So yes, we've been able to, for IDPs, we have a different strategy because there are different type of people. We look at their health needs. For instance, before we visit some of them, we send a questionnaire to find out what their immediate needs are. And some of the IDPs around this area here, sanitation is one of the big things. Clothing, food, accident prevention, those are the biggest, not the money. Those are the things they ask for. Clothing, okay? Then sanitation, water, soap. Those are the things we find in some of the IDP camps before food. Okay? Then when you now move on to orphanages, that's a different ball game. Those ones need money. They need medical support and also need accident prevention and sanitation. So you can see the order is different. So in that context, we've stratified the visits to IDPs. It's a different coloration. Orphanages, a different coloration. Hospitals, a different coloration. For hospitals, it's money. Those for discharge.